Yeah. Good evening, everyone. I welcome you all to this exciting forum of no thrombosis, which is interesting cases in neurology in thrombosis. My name is Dr. Ankush Gaikwad from Emcure medical team. It's my privilege to have you all the faculty members, as well as participants in this exciting forum where we will, our expert speakers will present some interesting cases of stroke, and we will have our faculty members to discuss and debate on the cases. So it's my honor to introduce our faculty for today, our course director, Dr. Ichaporia sir. Sir is a director and head of the Department of Neurosciences, Sayadri Hospital, Pune. So is the first neuro ICU and has first setup of neurology intensive care in Pune. He has been pioneer in thrombolysis treatment for stroke in India. Sir has delivered more than 300 public lectures and workshops on stroke. So he's a member of Indian Stroke Association and also president of Stroke 2012, organizing president, ISA Stroke School. So he's the founder of Pune Stroke Group, ex-president of Society of Neurosciences Pune and Maharashtra Academy of Neurology. So has been principal investigator for many multinational stroke trials and also awarded as health icon by Times of India Group. So welcome, sir, to this group, and thank you for joining today. I would like to welcome our moderators for today, Dr. Rohatgi sir. Sir is a professor at neurology at Gangaram Institute of Postgraduate Medicine and Research in New Delhi. Sir is a secretary at Delhi Neurological Association 2021 onwards. Joint Secretary, Association of Neurologists in Clinical Research in Mumbai. Coordinator for NABH and ISO 9001 for neurology. Principal investigators for more than 24 trials and over 47 publications in various journals of national and international repute. Has delivered more than 25 scientific papers in various conferences and guest faculty at prestigious neurological meetings and conferences. Our next moderator for today is Dr. Parul Dubey ma'am. Ma'am is consultant neurology at Manipal Hospitals, Goa. Associate editor of the book A Clinician's Approach to Neurological Disorders. Speaker and faculty in many national conferences. Contributor in the most prestigious reference book for neurology, Yearbook of Neurology, Neurosurgery 2012. Co-authored 2 chapters in IN Clinical Guidelines on Vertigo Management in India 2013 and 2 chapters in API Textbook of Medicine. Has won gold medal for pharmacology and general medicine. I welcome you, ma'am, for this in this forum.
Thank you. Thank you.
2 speakers. Our first speaker for today is Dr. Abbas, who has done DNB General Medicine and DNB Neurology. So, Dr. Abbas is a consultant neurologist at Department of Neurosciences, RJ and Apollo Spectra Hospital, Gwalior, and his clinical expertise includes stroke, epilepsy, movement disorders, to name a few. Our next speaker for today is Dr. Venkatesh Polgave. Sir is DNB and DNB Neurology and working as a assistant professor, Department of Medicine, Rajiv Gandhi Medical College and Chhatrapati Shivaji Maharaj Hospital, Kalwa, Thane. Sir has many multiple publications to his credit, poster presentations at various conferences, and also won multiple prizes at various conferences. So with this brief intro, I would like to hand over to this workshop to Dr. Ichaporia, sir, with a short note on recent ESO guidelines. So please, with your permission, sir.
Yeah. Thank you for the kind invitation and welcome to Dr. Parul Dubey and Dr. Rodgi. He will join a little later. But Dr. Parul, we are very happy to have you on this forum. And it's a very enjoyable forum. And I think this is the 10th such forum, I don't know, 9th or 10th. And we've had some fantastic cases. And one of them some time ago was also presented by Dr. Venkatesh from Mumbai, I think 2 or 3 months ago, and he's back on the forum. So we welcome you, Venkatesh. And I'm sure you will have a very interesting case to show us. And Dr. Parul has also been doing quite a few thrombolysis in Manipal Hospital, Goa, and I'm sure she will also contribute a lot to this forum. So before we start, yes, Dr. Parul, you want to say something?
No, sir. I said thank you. Thank you for the welcome.
Yeah, it's our pleasure. Yeah. So, before we start the cases, we thought we'll just share some very recent publication which has come, and it's a guideline really from the European Stroke Organization on the use of tenecteplase. So, Ankush, can you share those slides, please?
Yes.
And these have now come, we were discussing, since the last few months, the guidelines will come. It's only a matter of time, but finally they have come. So it's not in the American Heart Association yet, but European Stroke Organization, which is also a very prestigious body, has expedited the recommendation for tenecteplase for acute ischemic stroke. And this has been published very recently. This is an evidence-based recommendation and expert consensus statement. Sometimes the evidence is not enough, the trials have not been done enough. So therefore, it becomes an expert consensus statement. So from expert consensus statement, it can go on to evidence-based recommendation. So this is the first recommendation. In AIS, less than 4.5 hours, tenecteplase is safe and effective alternative. Up to now, it was level 2B. So now they are saying that for patients with acute ischemic stroke of less than 4.5 hours duration who are eligible for intravenous thrombolysis, tenecteplase 0.25 milligrams per kilogram. This is also, all that ambiguity is removed. Previously it was 0.4 or 0.2. So, everyone was getting confused. I think the Indian guidelines said 0.2, but now very clearly, and we've been using 0.25 only. So it's now come in print that tenecteplase 0.25 milligram can be used as a safe and effective alternative to alteplase 0.9 mg per kg. The quality of evidence is moderate, and the strength of recommendation is strong. So it's pretty robust. I think there is no ambiguity anymore. This thing of 3 hours or 4.5 hours, all that nonsense was going on. So now it's very clear, 4.5 hours and 0.25 milligram, very clear, the safe and effective alternative for alteplase. Next slide. Now, if you have, now we don't have too many of these mobile stroke units, but if you have a mobile stroke unit and there is facility for pre-hospital management, or, even if you're using the drip and ship method, I think it can be used for patients with acute ischemic stroke of less than 4.5 hours duration with pre-hospital management with a mobile stroke unit who are eligible for intravenous thrombolysis. We suggest tenecteplase 0.25 milligram over alteplase 0.9, and this increases the rate of early reperfusion and to shorten the time from imaging to treatment initiation. So now this is very clear that it has an edge over alteplase, and it increases the rate of early reperfusion and shorten the time for treatment initiation. Now, why is the evidence low? Because there are very few mobile stroke units in the world. So not many trials have been done, and therefore the evidence is low, but the strength of recommendation is also weak. This is okay. We don't have this here in India yet. We have it in 2 or 3 centers, but I don't know. For them, I think this is important. But for the vast majority of us, this is important because, we have to use this hub and spoke model. And, in a peripheral small hospital, we can prefer tenecteplase over alteplase and then shift the patient. So instead of mobile stroke unit, we can supplement it and say that, this is for a primary stroke center, even for primary stroke center, and then you shift the patient to a comprehensive stroke center for further management. So this also saves time. Next slide. For LVO, clearly now, lots of trials have come. So the quality of evidence is moderate, strength of recommendation is strong. For large vessel occlusion of acute ischemic stroke who are eligible for intravenous thrombolysis, we recommend tenecteplase 0.25 over alteplase 0.9. Intravenous thrombolysis should not delay mechanical thrombectomy. So for LVO now, clearly it has been shown to be superior. And this is now recommended over alteplase. So this is a very path-breaking, I think, for the first time, these words have been used. Now, we've been using it, and we've been more or less convinced that it's better and more effective. But to see it in print like this, I think it's a major advancement in its use. And, this ambiguity of dose is also removed. Next. Yeah. Now, regarding acute ischemic stroke on awakening from sleep or acute ischemic stroke of unknown time of onset. Next slide. Yeah. For patients with acute ischemic stroke on awakening from sleep or acute ischemic stroke of unknown onset who are eligible for intravenous thrombolysis, there is continued uncertainty over the potential benefits and harms of tenecteplase compared to alteplase. So not enough trial has been done, but expert statement, I'll just reduce this one sec. Yeah, so evidence is rather weak because, not much studies have been done, but all the members suggest that tenecteplase 0.25 could be a reasonable alternative to alteplase for patients with acute ischemic stroke on awakening from sleep and acute ischemic stroke of unknown onset who are eligible for intravenous thrombolysis after selection with advanced imaging, that is flare DWI mismatch or perfusion mismatch, as outlined in the 2021 ESO guidelines for IVT. So in these type of cases where we don't know the time of onset, you cannot give it unless you do good imaging, not only CT scan and CT angio. You will need more. So unless you do that, you should not use it in the people of this unknown onset or sleep. That means you should do either a flare DWI mismatch, which most of us are doing. And if you have perfusion, it is even better. If you find a perfusion mismatch, you are in very strong footing and you can use it. So the expert committee, though it is not evidence, so just remember that it's not evidence-based recommendation, but there are enough experts who have consented that it can be a safe alternative for alteplase, and tenecteplase could be given, though still we need more data. Next. In LVO, don't skip IVT if MT is scheduled. For patients, this is in a thrombectomy capable center. For patients with large vessel occlusion of less than 4.5 hours duration who are eligible for intravenous thrombolysis and are directly admitted to a thrombectomy capable center, all members suggest IV tenecteplase 0.25 or 0.4 milligram over skipping IVT. So definitely, now we've been saying this again and again and again and again, that don't skip the IV therapy. Even if you're doing MT or if the patient has come directly to an MT center, don't skip it. The interventionists are constantly on our throat and say, no, don't do it. Risk of bleed is a little more. It's not so. It's not so. So now it's come in print that you should give IV therapy prior to MT in all cases. Unless there is some bleeding or recent surgery or something, then you can do direct MT. But otherwise, you should do this thing. For patients with large vessel occlusion of acute ischemic stroke of less than 4.5 hours duration, who are eligible for intravenous thrombolysis and are admitted to a center without mechanical thrombectomy. All members suggest IVT with tenecteplase 0.25, followed by rapid transfer to a thrombectomy capable center. So this is the drip and ship model, where you give the IV tenecteplase and then quickly shift the patient. So you do the CT scan, it shows no contraindication, and you shift the patient quickly to a center for mechanical thrombectomy. But before that, give IV tenecteplase, and this is preferred over alteplase for large vessel occlusion. So this 9 out of 9 members have endorsed this type of expert consensus. Still, it's the expert consensus statement. So they have endorsed this. Okay, next slide. Yeah, that's it. So these are I think all this ambiguity is totally removed now. I don't think there is any scope for further discussion. The only thing is, little bit more trials need to be done for wake-up stroke before we can call it a recommendation. But I don't see any problem in it, though, because the trial is not done, it's not come in a recommendation. But very soon, even that trial will be done in a year or two, and I'm sure it will all come back. And certainly, tenecteplase has certainly hit a goal. I mean, it's hit the penalty, and it's won the battle. This debate was going on for the last 5 years, whether we should give it, not give it, give it, not give it, what dose to use, how to use. I think now all that ambiguity is removed. So this is just a little short prelude to today's discussion. Okay.
Thank you so much for highlighting on this ESO aspects, which is a recent publication which just came out 4 days back. And thank you so much for highlighting your aspects and your points on this perspective on this publication.
But we've been saying this, Ankush, in all our previous all our previous the no thrombosis seminars of this type. We've been saying all this, yes, but we didn't have it written in print. Now we have it written in print, so then therefore we are not talking through our hat. Otherwise people were saying, "Kya because Emcure is sponsoring this, therefore we are talking." No, we were not doing it even then, but now it is very clear that we were not doing it that way, and it was really based on sound scientific principles.
Absolutely, sir. In fact, it validated all your expertise, which we actually discussed.
And we've been saying this again and again for the last 1 year. Okay, the thing will come. Finally, it's come. Okay, so let's go on now. Parul, can you, Ankush, would you like to introduce, and Parul, could you take it ahead, please?
Absolutely, sir.
For the case.
Yes,
so maybe first, we will, with your permission, can we start with case from Dr. Abbas first?
Yes, of course.
Okay, so then we will move on to the discussion part.
Yeah.
So Dr. Abbas, please go ahead and please share your screen. Yeah, we can see the screen.
Yeah. Good evening, Ichapuria sir. Good evening, Parliament. Good evening, Anshul sir, and all the participants who have participated in this thrombosis seminar. I'll be presenting a very interesting case, which I encountered around a month back. Actually, I didn't know that I'll be presenting this case in this forum, so I don't have that good quality images, but still I have gathered as much as possible to show and to discuss the cases with you people. So the case details start with the patient was 62-year female with no known comorbidities. She presented with sudden onset right half body weakness within 30 minutes. They reached the hospital within 30 minutes of the stroke onset. And there was no history of any loss of consciousness or seizure or headache or any clinical involvement or any form of trauma or head injury. On examination in emergency, NHS was 12 out of 42. Pulse was regular. It was 88 per minute. BP was 160/86. Patient was off febrile. Sugars were normal. Saturation was normal. Patient was conscious, alert. There was slight dysarthria was there. There was left gaze preference. Pupils were equal and reactive. There's a subtle right human facial palsy, right hemiplegia, power of 2/5. So when the patient approached, whenever such a patient approached to our emergency, we announce a code stroke. So lab will be activated, and soon we'll be sending the investigations which are necessary for thrombolysis. Platelets were 2.4 lakhs. INA was within normal limit 1.1. APTT was 33 seconds. Creatinine was 0.6. So we got the CT scan done. CT scan did not show any form of hemorrhage or anything. And there were no early ischemic changes also. Since patient had come to us within 30 minutes of onset, so it was not evident much. So after obtaining the consent for thrombolysis, thrombolysis was done with tenecteplase using the dose 0.25 mg per kg. Considering her body weight was 68 kg, 17 mg bolus dose was given. Dose needle time was 30 minutes. And after 1 hour of bolus injection, NIHs reduced from 12 to 1. So there was a very remarkable improvement in the neurological status of the patient. Patient was later shifted to the ICU. While performing the CT head, we had done the CT NG of head and neck region, which was normal. There was no evidence of any large vessel occlusion as such. So post thrombolysis, the status was absolutely almost normal, except from subtle dysarthria. Patient had no weakness, nothing, no headache, no worsening of symptoms, and NIHs had reduced from 12 to 1 post thrombolysis. So patient had come to us in the night at around 9:30, 10 p.m. Exactly after 12 hours. When I went in the morning to see the patient had started developing similar symptoms in front of my eyes. Patient became stuporous. She developed right hemiplegia. She became aphasic. And again, there was left gaze preference, which recovered within 30 minutes. That was a clear-cut episode of TIA which happened in front of my eyes. So in that case, since I had only thrombolized the patient, I didn't know what to do in such a case. I was supplementing her with statins, hydrostatins, and all those new agents. But new anticoagulation can be given. Nothing was there. So, and literally, patient had 5 to 6 episodes in front of my eyes. I was literally watching her for 2 hours, and she was having recurrent strokes. So a wild thought came to my mind that I might have thrombolized some functional patient. Such a wild thought came to my mind at that time. But still, I was very sure on my examination part. So I got the MRI done. MRI done with the patient. So these are very small lacunar infarcts which were seen on the MRI of the patient. One in the higher frontal region on the left side and one in the left periventricular region. Very small lacunar infarcts. MRI showed lacunar infarcts in the left periventricular and left high frontal region. During that time, patient kept on having recurrent TIAs. Around 15, 16 TIA episodes were recorded in the file of the patient. Every half an hour she was having such a thing. So initially, I thought the patient might be having capsular warning syndrome, which could be because of lenticular striate branch thrombosis. So eventually, that will lead to completed stroke after a few days or something. But that won't be having any cortical signs. Like patient was having gaze preference, patient was having aphasia, sensorium was getting deteriorated. So there was something which we were missing. So we did the CT perfusion of the brain, which this is the perfusion map. The top two are the cerebral blood flow windows, and below two are the Tmax and MTT. You can see qualitatively the blood flow is maintained, but the Tmax is pretty prolonged. Based on the color coding, you can see this clear-cut right MCA hypoperfusion, and the raised MTT with relatively preserved PDB suggests significant mismatch, suggests that there is large penumbra which is about to get undergo some form of stroke in future. So with this perfusion scan, we took the patient to DSLR. Actually, everything happened within 24 hours, and patient had already got CT angio contrast in the beginning. For perfusion, again, she got the contrast. Again, now I was taking the patient to the DSA again to give the contrast. Although there was no comorbidities, there was no diabetes, there was no nephropathy, but still I was afraid because she was going to get a lot of contrast within 24 hours. So I had given Mucinex, hydrated her thoroughly so that she should not get AKI because of the contrast-induced nephropathy. So, although we had done the CT angio in the beginning, which was normal, but still I took the patient to the cath lab and did the DSA. DSA was absolutely clean. Absolutely clean. Now I had no idea what was wrong with the patient. There was perfusion mismatch, clear-cut perfusion mismatch. And apart from just telling the patient's attendant, I had nothing which I could do beyond this. So just to evaluate the patient, what was wrong with the patient, we need to find the etiology. So we got the 2D echo. I asked my cardiology friend. He came and he did the echogram, which revealed a large mobile shaggy mass on the anterior mitral leaflet and posterior leaflet. Although there was no history of fever, there was no history of although vegetations are friable and they'll be irregular. You can see the down image. The echo image shows it is a rounded sort of structure. Usually vegetations are friable and they will be very irregular. This is a rounded sort of structure. But still, we send the blood culture from both two sides to find out whether there could be some evidence of infective endocarditis. We don't know. And that might be throwing some embolic shower to the brain, which might be causing this. But there was no fever, there was no evidence of fever, sepsis, or shock. TE, we don't have TE, so we could not do. Holter was also normal. And later we put ELR, extended loop recorder, which was also normal. We had put for V, which was also normal. So, what was the etiology of this? We had got the MRI, cardiac MRI done. We have 1.5 Tesla MRI, but we got it done from a 3 Tesla MRI center. Here you can see the images in the right bottom. That was the SWI sequence of the MRI. That clearly shows hemosiderin deposits. Then I went into the literature and saw it could be a blood cyst arising from the mitral valve. In literature, there were blood cyst.
What's this?
Blood cyst. It was a blood cyst. I went through the literature. In literature, there are a few cases they have reported. Although there is no consensus study that it is definitely a case of cardioembolic, it's a cause of cardioembolic stroke. But we did not have any other reason to believe. We just had to believe that this was the reason for her recurrent TIAs and stroke. Fortunately, we could get some etiology. So the diagnosis made was the blood cyst arising from the mitral valve, and the mechanism of stroke was cardioembolic stroke. After 24 hours, patient was started on anticoagulation. In touchwood, there was no recurrent TIAs after 24 hours. And at discharge, and we discharged the patient on day 5, and MRS was 0 and NHS was 0 at discharge. I had suggested her for CTVS opinion for its removal or continuation of the anticoagulation. So this was the I had gone through the literature. This is an extremely rare case in cardiology also. This is extremely rare case in neurology also, considering as the cardioembolic etiology for any stroke. So I'd like to tell something about the blood cyst. They are usually detected in pulmonary, tricuspid, and mitral valves, but are rarely found in the ventricles or the atrium. They are mostly benign, but occasionally they can cause any form of valvular lesions, like they can cause stenosis, they can cause regurgitation also. Embolic stroke from mitral blood cyst has been reported in few cases in the literature. Actually, they have not mentioned how many cases they have reported so far. Cysts are basically thin-lined, cystic-like structure which will have a cobblestoning epithelium filled with non-organized blood, and ruptured thrombosis of the cyst can lead to embolization, and thus is a potential complication of such a blood cyst. Although various theories have been proposed, there's no definite theory what causes this. So various theories include enlargement of vascular spaces, heteroplastic changes of the tissue, becoming primitive pericardial mesothelium, inflammation, anoxia, hemorrhagic diathesis. But the exact mechanism nobody knows. Again, the follow-up data and the large number of cases are not available, so the natural course of this natural history of this cyst is again unknown, and there is no clear-cut consensus guideline for any form of management regarding the management of blood cyst. So this was my case, sir.
Can I ask you something?
Yes, sir.
Yeah, I'm Dr. Anshu.
Yes, sir.
On what basis did you reach the diagnosis of a blood cyst? Like, what was the
Actually,
basis?
yes. Actually, when I before Gwalior, I was at Delhi Apollo. There I had seen one case when I was working with Dr. Deep Suri. There I had seen one case, similar scenario. Second, if considering there was no evidence of any infective endocarditis, so infective endocarditis was ruled out. Sir. Third, it could be atrial myxomas also, but that mass was clearly arising from the valve leaflets. It was not hanging in the atrium. It was a clear-cut thing that it is arising from the mitral valve. Regarding the exact diagnosis, we need to take it out and then get it done, and get the biopsy done, and then we can prove it.
Yeah. Did you evaluate the patient for any underlying collagen disorder like
Yes,
you have in SCD, Lippmann's endocarditis?
Yes. Vasculitic profile was done. Even we do protein C, protein S, everything, MTHFR mutation, everything was done. From the blood side investigation, even VDRL, HIV, everything was conducted on that patient. at Gwalior.
Okay. I have a suggestion for you. Next time when the patient comes,
yes, sir.
Then I think you can get a cardiac MRI from Delhi, because I think a cardiac MR can maybe show us a better of this. So the case that you are referring to, did you were able to get a cardiac MR done for that?
Yes. I'll show the MRI picture. Yes, this is the MRI picture. Actually, we have 1.5 Tesla MRI. So I had got it done from a 3 Tesla MRI center. 3 Tesla, 5 Tesla MRI gives a better result in such a case. So I got it done from 3 Tesla MRI. So in the right lower quadrant, you can see, sir, it is clearly showing hemosiderin deposit. So it has to be blood accumulated somewhere.
Okay.
Dr.
Thank you.
Abbas,
Yes, sir?
Yeah, Dr. Abbas, was it a ruptured cyst or it is an? It is.
No. It had formed as. The surface was cystic. The surface was smooth. The etiology of causing it to be causing embolization could be either the clot might have formed over the cyst or cyst might have ruptured. But in ruptured cases, the surface of the cyst will become irregular.
Yeah.
That was not the case. So it was a clear-cut smooth lining. As you can see in this echo in the lower image, you can see the cyst images. It is smooth. It is pretty smooth.
So smooth cyst also can give rise to embolization, or?
No, definitely it can. It increases the surface area for the blood exposure, but it is smooth. It can lead to some form of thrombosis because it is
Right. Thank you.
altering the hemodynamics of the luminous flow of the blood. So it can lead to thrombosis, thrombus formation, which eventually can lead to cardiac embolic stroke.
Okay.
Yeah, I think fantastic case. I've never seen this, and I never knew this also frankly, Abbas. So really fantastic. And the way you have investigated and, gone ahead, it's really extremely creditable. And I think it's worth publishing this case, huh? And
yes, I'm planning to publish this case.
Yeah. Because I have not heard, frankly, I have not heard of this blood cyst. That's why I asked you 2-3 times, what were you saying exactly? So
actually, sir, the purpose of evaluating this patient was she is the mother of a High Court judge at Gwalior. She came running with 30 minutes. So that was the only option left that I had to evaluate her. I had asked her to, if you want.
No, that is immaterial. No, whether High Court or Low Court or this court or that court, that is immaterial. but really fantastic. But why does it embolize? Well, are there clots on top, or what exactly happens?
Actually, sir, even I did not understand much, to be very honest. I evaluated. I could not get anything in her body except this. So that is why I'm blaming.
Now, such a big perfusion mismatch and the vessel did not show anything, huh?
Nothing. Even I was surprised. Radiologist.
So then what is it? The embolus dissolved and went away, or what?
Could be, sir. Could be. Actually, I've been using tenecteplase at Gwalior. I have done around 45, 46.
Yeah, but how? I don't know. So, maybe all parts of the jigsaw are not there. But whatever it may be, maybe we don't understand because we don't have enough knowledge of this condition. It's so rare. But the way you have investigated and managed this case, hats off to you, and really, really fantastic. I mean, I'm really thrilled to see such a case. Parul, do you have to say something? Parul, Anshu?
No, sir. I think I have never seen such a case. That's why I was interested in asking him. So very, very, very unusual. I think we could not explain that so much of perfusion deficit also.
Yeah, exactly. All this time I was thinking of capsular warning syndrome. But, I think, Abbas, you mentioned very nicely that, there were cortical signs with capsular warning syndrome. You should not get aphasia and you should not get gaze deviation. I don't know whether that statement is absolutely true or not, but perhaps you are right. But there was an infarct on the MRI. Just show that MRI post this thing.
No, sir. Actually, I did not get it done post. At discharge,
when was this MRI done?
After 12 hours, 12-14 hours.
This shows the lesion in the corona radiata, no?
One image is showing at the left high frontal region, and one is at the periventricular.
Yeah, but that perfusion mismatch is dramatic, I must say.
Perfusion is because of perfusion mismatch only, sir, I took the patient for DSA.
Yeah. So this perfusion study really helped us. It really tilted the balance, and because I was thinking in my mind that it's a small vessel occlusion because the angio was normal, CT angio was normal. So I was thinking of small vessel, but obviously it's not small vessel; it is large vessel, and it's not seen on the CT angio. So the way you have pursued it, I think it's fantastic. But it also tells you that we must look at the heart in every case. You must do this thing. You must do an echo, preferably a TE if possible. But if not possible, at least a transthoracic echo. And that MRI is just fantastic. We must use cardiac MRI more and more. Now we have 3 Tesla machines everywhere. So, not every 3 Tesla machine can do it. You need expertise in that also. But the way you have done it, I think, is really fantastic. So I really must congratulate you very heartily for this case.
Thank you, sir.
Yeah.
Very interesting case indeed.
Yeah.
And so for me, the take-home message is that echo we must never delay. Even that's a simple thing that we can do. And of course, we must be using cardiac MRIs more and more. That's the take-home message for me from this case.
I remember somebody, I think, had shown that, this cyst, I mean, you're saying it's a blood cyst, but somebody had shown that once, that strongyloid, not strongyloid, strongyloid worm was there. Parasite was there on the endocardium, and that was throwing emboli. And can it be, I'm just, saying off the cuff, can it be cysticercus, sitting?
No, sir. No, sir, it cannot be, because the MRI in the susceptible.
Because of that SWI image, that's why we are saying it is blood. But it looks like a cyst, so it can be any cyst. It can be a parasitic cyst, which is throwing him. I'm just talking, off the cuff. But suppose that SWI had not shown that, then I distinctly remember that there was a patient from Africa, from Gabon actually, and he had this strongyloid sitting in the endocardium, and that was throwing emboli into the brain. So, I mean, this is very unusual. I mean, I don't think I'll ever see it again in my life. But even this, maybe I'll never see again. So therefore, fantastic, really fantastic. I have no words to express it even more than I should. Okay, so well done.
Thank you, sir.
Yeah. Thank you. So shall we go on to the next case?
Yes, sir.
So, good evening, all. Am I audible?
Yes.
Good evening, sir. So, I'm Dr. Venkatesh. I practice in Thane and attached to Government Institute. I practice in constraints with constraints. Last time also I had presented to sir, and a similar way I'm presenting this time also. So, so my first case is she is a 53-year-old female with a history of diabetes, no blood pressure, and now presented with transient sudden painless vision impairment in the left eye, and it has recovered in around 5 minutes. There was no other cranial nerve involvement or limb symptoms. So she was evaluated. Blood pressure was slightly higher side, likely to be new onset hypertension. Blood sugar is not optimal. HbA1c 9.2. She had dyslipidemia. 2D echo was done, which showed left ventricular hypertrophy suggestive of underlying hypertension. Ejection fraction was good, and there was no RWMA. So further, she was evaluated, and this is evaluation by an ophthalmologist. So carotid Doppler was done, and we can see here left side, which is the affected side, there is thrombus in the left internal carotid artery causing complete occlusion, and they had suggested MRI and further evaluation. So this is the first thing. So whether at this moment, at this junction, what should be the ideal treatment? There is no history of strokes in the past. There is no cardiac issue. So she was not any antiplatelets, etc. There was no history of TI, etc. This is first time she has got these symptoms: left eye sudden impairment of vision with left ICA thrombus. So what should be the ideal management for the case? So whether it should be a dual antiplatelet plus statins, or single antiplatelets with anticoagulation, or purely just anticoagulation. Sir.
Are you waiting for an answer?
Yes, sir. Because she has no history of stroke, etc. And this is done by ophthalmologist. So I had just had these doubts. So if a case directly comes to us,
I would anticoagulate her. DSI showed a thrombus, you said, no?
No, sir. Carotid Doppler was done. This was initial evaluation by ophthalmologist.
Carotid Doppler showed a thrombus. So yes, so these large thrombi in the carotid artery. Was it in the COVID period or something?
No, sir. This is last month's case.
Okay. So I wouldn't say standard treatment, but accepted treatment just now is to give antiplatelet, single or double, with anticoagulation with low molecular weight heparin for 2 to 3 weeks, and then repeat as a Doppler or a CT angio or MR angio or something to see whether that thing has dissolved, and then to if there is an underlying plaque to manage that plaque. So you should look at it, give anticoagulation with Clexane for 1 or 2 weeks, and then repeat the procedure.
And whether immediately we should anything else from you?
Yeah, I think first of all, we should do a MR angio, neck and brain, to see how long is the thrombus, and are there any asymptomatic infarcts which are occurring inside. That is the other thing that we should.
Yeah. So that was my next question, sir.
Yeah,
whether
so
brain imaging should be done.
Brain imaging, and the other important thing is sometimes these thrombuses are real soft. So when you try and do a Doppler repeatedly with a probe, you can break off, the thrombi can break off and can go up. So that is something we have to be careful. So I think the next step should be an MR angio, neck and brain, and to see if there are any asymptomatic infarcts. And I think most of us follow that low molecular weight heparin with a single or double antiplatelets in these patients. So I think that should be the standard plan of treatment.
So whether DSA should be attempted in first.
Why do you want to? Because you want to do a DSA only if you are contemplating some intervention. Most of these cases, even the vascular surgeon or the interventionals are usually little reluctant to do any kind of procedure because the risk of thrombus breaking up and going up is very much higher. So the risk-benefit ratio is basically in the other sense.
See, to do an invasive imaging procedure is not indicated. There are so many non-invasive imaging modalities like MRA or CTA. So why, unless you're doing intervention, why do you want to do an invasive imaging procedure?
Yes.
I mean, I don't see any sense in that. Yeah.
True. Yes. Yeah. So that was the thing, and then suddenly she presented with again vision loss in the left eye, and there was no associated any other cranial node deficit or any limb weakness. So now she has come within window, and this was the scenario, sir. This is the video of the patient. Left eye vision impairment is there, and we can see the left pupil. There is clear-cut RAPD. Right is constricting, left is dilating. Was the fundus photo. This was actually taken afterwards, but I have just put up. So it is showing cherry red spot with pale retina, and their attenuation blood vessels are seen, and cattle tucking is seen, but I could not appreciate that. But overall, it is suggestive of CRO end of picture window period.
When did this occur?
Hello?
When did this recurrent eye problem occur?
Sir, this is before starting of any treatment, sir. So she was being evaluated.
Came to you after the second.
Yeah. So now she has presented in the hospital basically within window period with painless loss of vision in the same eye.
How many days after the first episode was it?
It's 3-4 days only, ma'am. She is being evaluated. Yeah, she is being evaluated for the same. And
in how many hours did she come to you?
She was within 2 hours.
Within 2 hours.
Yes.
And had you done an MRI by that time already for her, or
no? She was being planned, like I discussed. So till that time the investigation was done. The further investigation was awaited. And now there was sudden episode.
And she was already on antiplatelets and anticoagulants. Nothing at all. Okay.
So, what was the diagnosis of the loss of vision? Like it was a CRO?
Investigation was done, and like kind of.
So
Yes, yes. So this was
was
the
it a,
fundus, sir. I think
what it was it a CRAO?
Yes, this was done by ophthalmologist, and this was the picture. This is so. This was the
Okay, so did you do imaging?
Correct, sir. So, so that was the thing, sir. Like she knew, now also she was not having any limb weakness or any limb symptoms or any other cranial nerve involvement. So the question is within window period. So whether now we know that the diagnosis is CRAO. So whether we should directly thrombolize in such cases, whether imaging of brain is needed.
You must do imaging. Do imaging. It takes 5 minutes to do.
True. I was just curious whether thrombolysis should be done because there is no, and we know that this is kind of without involvement of brain parenchyma. This is.
I would like to.
No, you don't know that.
Okay.
Yeah. So I think you should do imaging, and then if imaging is okay, you can thrombolize.
Yes. Okay, sir.
Yes, Dr. Abbas wanted to say something.
Actually, sir, by definition, stroke includes brain parenchyma, retina, and spinal cord. Actually, we don't encounter CRAO very often, or spinal cord infarctions very often. So we are a bit reluctant, or as such, there is no straightforward guidelines also regarding the thrombolysis in both the cases involving cord and retina. But in most of the US centers, they usually thrombolize the patient presents within the 4.5 hours.
Yeah, but of course you put image and then thrombolize.
We have to evaluate the brain parenchyma.
No thrombolysis should be done without imaging. No thrombolysis.
Yeah. So like for imaging, sir. So this was the brain MRI, diffusion and ADC, and so the flare. So brain parenchyma was completely normal. One more question here was, sir. If we see the flare, sir, there are no periventricular ischemic changes. She is diabetic and there complete occlusion of large vessel and brain parenchyma small vessel. This is what we see commonly with hypertension and diabetes underlying. And here in this case also she has hypertension and diabetic she was. So but parenchyma was looking completely not. Flare is quite okay, sir. So so there is complete different etiology kind of small vessel disease, or it is how that entity is there, because here you can see.
What is your question?
So my question is, sir, though the patient is known case of hypertension and diabetes with sugars on higher side going on for a long period with large vessel complete occlusion on the left side, if you see look at the flare, the periventricular changes are almost nil, sir.
So good for her.
Yeah. So like whether that
it's not an exclusion or by any stretch.
No. I was curious because we tend to see.
So she's lucky. She's kept her brain in good shape.
But the ICU got the thrombus.
Yeah, completely.
Yeah, but the brain is okay.
Yes.
So we see such cases, sir, like with hypertension, diabetes, but periventricular commonly we see. But here it is completely normal. So pathophysiology.
Okay. So then, did you do an angio at that time? MRI?
Yeah. Yes.
Yeah.
So this was the angio, sir. And we can see that there is complete occlusion again of the left IC. We can see. Hence, thrombolysis was done, sir. So she was, like we say now, the dose of tenecteplase is 0.25 milligram per kg. And since she was within window period, she was thrombolized with tenecteplase. So the thing is now, we should go for DSA or?
Why do you want to do a DSA?
Complete occlusion.
Yeah, complete occlusion.
No, DSA you want to do for what? You want to remove the clot?
Because patient had this second episode which patient has occurred now, and there is consistent, like earlier it was kind of TIA kind. She has recovered. Now she has persistent vision impairment. And she has not recovered.
But do you want to do DSA for thrombectomy, or for what do you want to do DSA?
Thrombectomy.
I wouldn't do thrombectomy.
Or whether with such a large clot, whether the brain parenchyma at risk can kind of
No, I mean, see, that is all conjectural. Whether brain parenchyma later on will get affected, we don't know. If it gets affected, we'll do thrombectomy. But just now, there is no brain affection. And with tenecteplase, you never know, it may have improved. I don't know if it has improved and no parenchymal lesion has occurred, then I'll wait and give Clexane for a while and then see it again.
But thrombolysis is valid in such case.
Huh?
Thrombolysis is valid.
Yeah.
Thrombolysis
I would
is valid.
thrombolize her. Yeah.
Only I will just add one point. It is said that for CRAO, basically the retina can withstand the ischemia for about 105 minutes. Although we are thrombolizing in about 4.5 hours, for CRAO, I think the period is a little short. I think 105 minutes is what they say is the central retinal artery obstruction. The retina can withstand ischemia. So we have a little smaller window here. This is what I think. You must have reviewed the literature.
No, sir. This is recent case. Yesterday I came to know, sir.
Okay. So then you gave tenecteplase. Then what happened?
Right. So because it was complete occlusion and this was a recurrence, she underwent DSA to check whether the occlusion got removed. But like we see with even tenecteplase, there is now complete occlusion, and this is now the case. So even after tenecteplase, she has clinically also not improved, and the occlusion has not. It is complete total occlusion, sir.
So her vision didn't improve.
No, sir.
So as I said, the window in for CRAO is a little less. It's 105 minutes. You can review the literature, but it's about 105 minutes. So I think that is the reason that she didn't improve.
Yeah. Or it may not have recanalized. Also.
Yeah.
It may not have recanalized. We don't know. In the DSA, could you see the ophthalmic artery?
So here they have not mentioned.
No.
Non-visualization of left ophthalmic artery they have mentioned here.
What is the written?
PCA angiogram. Here, sir. Non-visualization of left ophthalmic artery.
Yeah, so it did not recanalize.
It did not recanalize. Okay.
Yeah, it did not recanalize.
Okay.
Yeah. But for such cases, still now this is so complete occlusion, so nothing can be done. But if the thrombectomy was possible, if so, we should go ahead with thrombectomy.
So, but it will not serve you any purpose. Your vision is not going to come back. Your vision is not going to come back.
Yes. Even though this case like 99 or 90% of
I think the only thing that one can try and think is if you can do a selectively go into the ophthalmic artery and try and give a local TPA. I think that is something that you can maybe think.
Okay. Because
but people have tried that, Anshu, but
people have tried.
The caliber is so small
it's difficult
that you cannot do that selective catheterization of ophthalmic. It's too small. I think it's 2 millimeter or something. So I've reviewed this thing, whether you can do intra-arterial thrombolysis, but usually, I don't know, this was some time back. Maybe there are some new catheters which are very thin, which can go. But as of now, as per my knowledge, which was about 6 months ago, there weren't catheters to, go into that vessel. It was too small. Okay, then what happened, Venkatesh?
So now her vision has not improved. She is on anticoagulation and antiplatelets with statins.
Yeah, but
she's in follow-up. This is a recent case,
So maybe you can do the Doppler again.
Yes,
and see whether it's opened up or it's a chronic occlusion. Does it look like a chronic occlusion?
Sir, whether that was another question, sir. With carotid Doppler, whether they are able to see, because here I don't know, sir. They have done earlier, and they have just mentioned echoic thrombus in the left carotid artery.
They are able to make out thrombus from plaque.
Yes.
So it may open up. You never know. If you do it after 2 weeks, it may open up.
Yes. So she will be in follow-up.
Yeah, I think you should follow her up. and do a angio again. Angio or Doppler. Doppler is easy to do, and you can repeat it every day. You can do it every day, and see whether it's opening, and then see it and then decide. But unfortunately, the vision is gone. So, we could not help her there. Maybe because the thrombus load was too much, and the drug did not penetrate into the artery. If it is totally occluded, there has to be some forward flow for the drug to act. If it acts on a clot, if it's a clot like that and it's just acting here, it won't work. There has to be some little forward flow. If there is some little forward flow, then there is chance of reopening of the vessel. But if it's totally blocked and the length is long, then IV TPA does not work. Then you have to do thrombectomy. But here now in the ophthalmic artery, now to do thrombectomy is impossible. Yes. So
again, sir, for thrombectomy also the time window would be smaller, as Anshu sir mentioned.
Yeah. No, I think the vision, by the time you organized that, 1 or 2 hours to do thrombectomy, I wouldn't have done thrombectomy. I think what he has done is quite good. Unfortunately, it doesn't work. In many cases, it doesn't work. I mean, therefore, it's not in the guidelines, and there's no proper, luckily you are able to diagnose it so quickly, which is of course extremely creditable. Most of the time, the ophthalmologist doesn't refer only. And they think of glaucoma and they think of something else. And, to refer to a neurologist. So this is the problem. These single...
sudden painless.
Painless vision loss, they don't refer only, and they refer after 1 day, 2 days. You can't do anything. So it's very creditable that, this case was referred to you so quickly and you could diagnose it and you could do the MRI so fast, and very creditable. Unfortunately, it didn't work, but it doesn't work every time. It depends, if it's not recanalized, it's not recanalized. What can you do? So, but anyway, the workup has been excellent. And Parul, you want to make any comments on this?
So one comment was just an addition that, of course, to diagnose sudden onset painless vision loss in the ER is difficult, because sometimes it is retinal hemorrhage, means you have to be really good at looking at the fundus, or an ophthalmologist should be available. That's one other point. And I was just, a thought was coming to my mind whether an increased dose of tenecteplase would have been more effective, if at all, because as you said, it couldn't penetrate the clot. But of course, we don't have any recommendation. Yes.
Unless there is some forward flow now, these thrombolytic agents will not work. And if the clot load is high, it won't go in. So, some little, or the clot has to be little porous, type of clot, clot morphology. Thoda, it has to penetrate into and it has to mix in the clot. Unless it mixes in the clot and goes little forward, how will the thrombolytic agent act? It can't act. If it's just touching the surface of the clot like that, it's not going to act. It won't be able to dissolve. It has to penetrate into the clot a little bit. Only then it can lyse the clot. So that probably, clot load was high, recanalization did not occur, and therefore this thing. But I would certainly continue with Clexane for a while and do a Doppler after every 3-4 days at least and see. And you can repeat it as many times as possible. It's very easy. You need just a good operator to do it. And it's not too expensive also. MRI and all little expensive, people may not be able to afford it every 2 days. So this is very, very nice method of doing it. Anshu?
And also
I think both the cases are very nice. I think both the cases are very nice, very nice. I think this was worked up very fast. Because I remember we have most of these patients of CRO, they come to us very late.
Yeah, very late.
In fact, actually what happens is that the ophthalmologist, they refer to the cardiologist. Once they see that.
No, but in this case, he has done such a beautiful fundus photograph also. Within an hour or two, within half an hour, he has done a fundus photograph and done this. So it's really, really fantastic. I must say, very fast work. Not many people can do that.
I think both the cases were very nice. I think it's really every time we see new things.
New things.
We are still, our learning curve is stroke is still.
We are at the bottom of the learning curve.
Absolutely.
Okay.
Another point of in management of this case is to maintain somewhat high BP because of that.
I don't know, this permissive hypertension, whether permissive hypertension, certainly one would give fluid, but one wouldn't give vasopressor to raise the blood pressure. So, this permissive hypertension, it has not been really, unless it's a hemodynamic stroke. If it's a hemodynamic stroke, then there may be a role for permissive hypertension.
Yeah. So there's a thrombus.
If it is occluded like this, I don't think there's a role for permissive hypertension. And, especially if you've given TPA, or TPA or tenecteplase, if you get the blood pressure up, he may bleed. So that we are terribly, terribly scared of. So,
or avoiding hypotension, we may say so.
Yeah, avoiding hypotension to definite.
Yes.
But you've given a thrombolytic agent, so then you don't want to raise the blood pressure. But if it was a hemodynamic stroke, on posture, or the BP was falling on standing position, and he's getting symptoms on standing, or changing posture, then yes, then there is a role for permissive hypertension, but not if it is occluded like this. And definitely not after giving thrombolysis.
Yeah.
Sometimes they give ocular massage regarding.
Yeah. This ocular massage. All these things have been used. Ocular massage, then steroid, and this. But none of them have been found to be, in proper trials, none of them have been found to be effective. This ocular massage business, these ophthalmologists love to do that. And then they don't refer, they do that ocular massage, but they will not give thrombolytic agent. That's a double whammy, It doesn't work. It doesn't work, that ocular massage. And then hyperbaric oxygen or something of that sort they do. But it's very creditable that the ER people referred, they did a fundus photograph, and still they referred very quickly to a neurologist. That is very creditable. That doesn't happen every day. It doesn't happen every day. So
one thing I would like to add.
Yeah.
Actually, so far we are having in cardiology cases, we have got drug-eluting stents, drug-eluting EVD catheters are also there. So in case for thrombectomy where the approach, we cannot approach like ophthalmic artery, we cannot approach directly for intraarterial thrombolysis or M3, M4 segment of MCA. So in that case, in case if in future, if any catheter is developed with drug-eluting thrombolytic.
Drug-eluting thrombolytic agent. How do you get that? How do you get that eluting thing, stent inside into M3, M4?
Because
that curve, that M2, and then it curves like that. You have to negotiate that. That maybe it'll occur. May not be in my lifetime. In your lifetime, it may occur. Who knows? So never say never. Something new can come. I'm not saying it can't be done. It may be possible. So let's hope. I think we've had a lovely program, and both these cases have been excellent. And we must congratulate Dr. Abbas and Dr. Venkatesh for very, very good presentation. And, bringing out, all the nuances in stroke management. There are, everyone thinking that what stroke, what are you going to do? But look at the nuances, look at the small little things here and there, and how you can pick up, how you can make life better for patients. So I think it's a very, very interesting session that we've had. We have, as usual, overrun the time, and I'll hand it back to Dr. Ankush Gaikwad for his remarks.
Thank you.
Thank you so much, sir. I think it was a phenomenal workshop today, and it was thrilling sessions. I once again congratulate and thank Dr. Abbas and Venkatesh, who really drive the show, and our faculty members who really gave some good insights and actually contributed to knowledge of all our participants. So thank you, Dr. Ichapuria, sir, for your insights, and thank you, Dr. Anshul sir, and Dr. Parul Dubey ma'am, for your great insights on the cases. With this, I would like to thank all of the faculty members, our speakers, and dear participants for spending time together. And I hope you learned a lot from this session today. So thank you so much.
How many participants were there?
We had, sir, total 163 participants.
Oh, wonderful. Wonderful.
Yeah.
Wonderful.
Yeah. So this program is going good, huh?
Yes, yes.
Actually, sir, आज कम है, नहीं तो हमेशा अपना 200 क्रॉस करते हैं.
200 क्रॉस करते?
हाँ, 200 क्रॉस करते हैं सर अपना हर बार. आज 163 है.
अच्छा, क्यों आज पार्टी है क्या किधर?
क्या
Okay, chalo, thank you everyone.
Thank you very much. Thank you. Good night.
Thank you, sir. Good night.
All the best.
Thank you, sir.